And yeah, these have been great. So.
Hell yeah. All right, Adrian, you're up.
Hey guys, I'm Adrian. I am a second year at PT student at Columbia. I'm one of James' classmates, actually. Was there another question?
Crushed it. No, that was it. Got a
Okay.
dank firecracker behind you. Cool vibes. James, we'll have you go last. So, Logan, how about yourself?
Hey guys, I'm a second year Kairos student from St. Louis. I've been going to these talks for quite a while now. I think they're pretty awesome. So looking forward to this one.
Dope. All right. Juan, let's have you go.
Hey guys, Juan. I'm actually not starting my PT program till May, but I just kind of wanted to get in this to, start feeling it out. And I'm based out of Florida.
Which PT school are you going to go to?
UCF, so Central Florida.
Solid. All right, Derek.
Hey everyone, I'm Derek. I'm a second year Kairos student at Logan University in St. Louis.
Party. Let's see, messed up. Okay, Andrew.
What's going on? Andrew Gillihan, second year PT student at Arkansas State University in Jonesboro.
Solid. Tiffany.
Hi everyone, my name is Tiffany. I'm a second year physical therapy student at Samuel Merritt University.
Dope. Ben Lewis.
What's up, everyone? I'm actually a practicing physical therapist in New York. Been out for a year now and been a fly on the wall for most of these talks, but I've been enjoying them.
All right, Alex.
I'm so cold. I was outside and I couldn't get the door open because my hands are so freaking cold. But anyway, hi. We're having a good morning. I am a second year PT student and athletic trainer and strength coach in Boston. I go to Simmons right now, and that is all. I'm gonna thaw now.
Solid. Love the background vibes. Pink light.
Yeah, thanks. I might actually shut that off because it's a little you can't look at me without feeling like I have an aura.
It's a little abrasive, but I like it. Ben Lee, let's have you go.
You guys are doing brief intros? Sorry.
Brief intros.
Cool. I'm Ben. I'm a first year SPT at Northern Illinois, also a strength coach at a youth basketball facility that's currently reopening pretty soon, which is cool. And Chris has been a super cool mentor. Got with him through Zach, through Level Up. So yeah.
Sweet. And then I think last one, Isaac. Are you free? I know you're blacked out.
No, yeah. Hey everyone, I am Isaac. I am a second year DPT student at the UT Health Science Center in San Antonio.
Party. All right, I think I got everyone. So James, you want to give a little intro on yourself and then a brief intro on the paper, and then we can dive into it?
Yeah, so first of all, James, nice to meet you guys. I am a part of the clinical athlete community where I met Chris, and I am a second year DPT student at Columbia University, so I'm Adrian's classmate as well. And I'm excited to be talking about this paper because it's something that actually is a pretty interesting topic that I'm really diving a lot deeper into and trying to get a good sense of how it can be applied to practice as I start going through clinicals and whatnot. So I'm sure, and since there's a lot of students here, I'd love your inputs on and your feedback on kind of some of the things we go over. And for Ben, since you're a year out, I'd love to hear your perspective too in regards to if there's any parallels to what you see in the paper and your practice as well. So that'd be awesome to share with us. And I just kind of wanted to start by just giving a brief overview of the paper. And just to kind of give a sense of, first of all, this is my first journal club where I'm leading. So, give me some feedback or, Chris, I'll let you help navigate this if I'm going off course, but I'll try to stay on topic. But regarding the paper, so title, right, towards an ecological grounded functional practice and rehabilitation. And a lot of what this paper talks about is one of the major frameworks of motor learning that's kind of really growing in terms of application and popularity is ecological dynamics. And it's taking a look at how this particular framework for motor learning and motor control falls in parallel, falls in line, and fits better with the ICF model. And it's something that is very emphasized in my program, and I'm sure in a lot of the other programs across the nation and whatnot, across the world, right? And a lot of it has to do with highlighting the discrepancies between how we practice in regards to how we apply and consider how people learn movement. And knowing what we learn, knowing what we know about perception and action and some of the developing research that's coming out, it really highlights the discrepancies in how we actually coach people and how we actually treat doesn't really fall in line with how we're assessing and we're considering. And I think this paper really just tries to prove or kind of like provide the case for like switching frameworks and creating like a call to action to like switching from really isolating your assessment and treatment and having it more integrated with functional therapeutics, or what they would consider like taking a look at the relationship between the environment and the individual. Because ultimately what we're trying to do is we're not just trying to improve function or impairment, we're trying to improve somebody's ability to navigate their environment. And a lot of that has to do with assessing them in their environment and taking a better consideration of how we can better do that in practice. I just wanted to provide a couple of like highlights of the paper, kind of talk about a couple of points that I really liked. And I'd like to open the floor to kind of like, if anybody had any thoughts regarding the paper or stuff that stuck out or they weren't really sure about, we can kind of start to talk about that. But one of the things I really liked about this paper was the role of how motor learning theory can be better implemented into practice to fit this ICF model that is so heavily emphasized. And something that I really liked about the paper was how it highlighted one of the discrepancies I saw in my first clinical practice that I actually just finished maybe like 4 weeks ago. So I did my first clinical field here in New York City. And one of the things that was so heavily taught in my program was this implementation of the ICF model, assessing or doing your assessment based on looking how the individual is functioning, but taking a look at environmental factors and other factors that could be contributing to disability. But then I looked at, as I started to kind of go through and working with more patients, interventions were very biomedical, kind of like, this is, we're doing this whole assessment of this individual, their environment, how they're functioning. We're getting a thorough subjective and assessment, but then the interventions are so mechanical, kind of like, oh, this is weak, so the intervention is going to be this. So, you know what I mean? Like, it was very like, we're just addressing muscles, whereas like it didn't really fit with the style of assessment. And I saw like, it was really influencing how like patient expectations. It was influencing the language used around like the outcomes, as well as like direction of treatment. And I just saw this paper really highlighted and kind of put it all together very clearly in regards to how we can better use theories of perception and action and motor learning to fit with this ICF model. So with that, I just wanted to open it up. So did anybody have any particular interesting points they wanted to bring up about this paper?
One thing that I highlighted, because when I read it, I was like, oh, mic drop. I wrote, put simply, arresting a disease process or reducing its symptoms may improve functioning, for example, due to reduction of pain, but this goal, though laudable, may leave function unchanged. So I just felt like that was a good complementary, maybe not a contradiction to what exactly you saw in your clinical rotation. If we're just focusing on the disease or treating the part, there may be some improvement in function, but possibly not if we're not thinking more contextually about it.
Yeah, I definitely highlighted that section
sorry.
too. No, go ahead.
I was just going to say, yeah, I feel like we probably all saw that. We're like, yes. The thing that it makes me think of is, obviously I love having these conversations and I love thinking this way. I think the limitation that is probably run into is more the model of our healthcare system, in that the insurance-based model of PT doesn't afford us that opportunity. So the example that was used, like playing video games, health payers don't care about playing video games, which is, part of the problem. But I wonder, what's the reconciliation of like, we all as budding or practicing therapists know that this is the way that we want to practice. But then how do we balance that with, okay, what is the insurance-based model going to allow me to do to fit within that? Because obviously that's a different conversation to address that piece, but where do we toe that line, or how do we find the ICF model that can give us function, but still allow our patients to see us?
That's a really good point. Actually, I thought about that too, especially given the setting and your practice environment. Like, do you have the time? Do you have the opportunity to actually dive deep to better understand like these entry points to kind of create these changes? And I think one thought that I had was if you apply this framework or like perspective when you start treating somebody, I feel like knowing like the goal is function, you're going to be kind of going towards an intervention that's going to address that more directly instead, like sooner than later, if that makes sense. So I feel like even if you're limited in time, obviously it's a lot easier if you have like that full hour or whatnot to dive deep. But I think, and that's definitely a big constraint. But knowing that if you have this as a basis of your like framework, like what you're going to look for, you can be more specific instead of kind of like taking in a bunch of information, objectives, like you kind of look at it differently. But I definitely see that being more of an issue, like in a very fast paced, like model and environments. I don't have, like, the last clinic I was at was very like, it was a little bit more chill. So I actually can't really speak to that. So I'm curious if anybody else has actually experienced that firsthand. Or maybe not.
Yeah, or even I just wonder, because I'm sure. So quick question, because I missed some people that introduce themselves. Can you like give a sign if you're a student right now?
I think all of us are students except
Ben.
for Ben Lewis. Yeah.
Okay, because and correct me if I'm wrong, at least like in my program, I mean, we don't really talk about some of the realities from a very like tangible perspective of, hey, like you're going to get out and you're going to have to make a lot of cases to insurance that is going to directly influence the way that you practice. Because I think that's what's so hard about this conversation, and I don't want to derail us too much away from the context of the paper, but what, like, where do we change our framework the entire time, or do we sort of get to a point of like, all right, the healthcare payers will do this until this point, and then like I can tie their function? But that's where it even says it in the paper talking about cost-effective care. Well, a lot of the cost-effective care now actually becomes out of pocket, because you're getting value-based care versus some of the insurance-based models where they have to work within their confines.
I think to tie it in with the paper too, part of it is getting to the to actually address function, like the model being, you have to look at the relationship between the individual and their environment and make it very goal specific and context specific to the individual. So in terms of it being cost effective, like addressing those functional limitations sooner rather than kind of the point that Adrian brought up, you can address some of these impairments or these limitations, but they might not address function whatsoever. So technically you'll be it'll be more cost effective in the sense you're actually addressing them sooner. I think, but in terms of the framework, I think if you take that into consideration, it also just makes treatment, whatever time you do have with the patient, more meaningful. So even if it is like the one thing you get to address and you're addressing like that one thing that they want to get better at, if you keep that in mind, like right off the bat, like you're going to get to work on that sooner than later, rather than if that's kind of the point I was bringing up earlier. But like, again, time definitely is a limiting factor or constraint. And, but I think the sooner you get to addressing that function and kind of figuring out what you can address that's meaningful and context specific to that person, the better it's going to be.
I think too, to go off of that, I mean, I know in our chiropractic program, everything is very linear. So, I mean, if you understand your basic sciences, you can essentially follow a pathway to fix a quote unquote problem. And I think a lot of this context-based approaches that we see here where we can't remove the patient from their environment gets very difficult and very uncomfortable. So naturally, we either resort right back to those linear mindsets, or we just don't know how to continue to improve further. Similar to what Alex was saying, because of our current healthcare system, that we kind of continue to fall back on this reductionist mindset and continue to just look at, you know, either the mind or the body as this separate entity, instead of learning how to incorporate both within a clinical setting. Because at the end of the day, I mean, it's going to be really hard to fully incorporate their environment because we've already removed them from that environment and they're in our clinic. So, you know, learning how to connect their environment in our own little world, I think, can get difficult. And then that brings up, you know, the idea of more telehealth or home case visits where, you know, depending on the scenario or the person that we're dealing with, it may be more beneficial to go to them instead of having them always come to us. But again, that's another barrier, because do we always want to do that, or do we have the means to do that?
That's a really good point. And it kind of brings up the topic of how those limitations or constraints kind of like influence the kind of questions you ask or the kind of information you're looking at. So you're right, like somebody comes into the clinic, they're already removed from the environment, from the context of the thing that they want to get better at or improve. So how is that going to shape the kind of information we look to gain from that interaction? And I think that's also something that has like that this topic kind of always brings up. Like, we understand, all right, we have to take into consideration their environment. We have to take into consideration like the context in which they're moving, and how the fact that they're in front of you is going to influence that, and whether or not you're going to get the best picture of like how they're actually moving when you're not with them. But then it's like, now how does that influence how you try and go about getting that information? So it goes about like, how does that influence your assessments as well? Like, so already just changing the framework changes like how you want to try and assess the person. I think that's one of the, regarding this topic or this paper, it kind of makes the case again for like, you know, having this framework also is going to influence the way you practice in terms of how you know, whatever, in regards to like how much time you have. Like, it doesn't really matter. It's more so like having this as the foundation is going to influence everything else, because it's going to take you away from this like mechanistic reductionist approach to like addressing muscles, and more so like, all right, let's get a little bit more information on like other things that are a little bit more important. But I definitely think language is part of it, and that's something I'm still trying to figure out myself. So that's definitely a good point for sure.
I think even what you're saying right now with the language piece of like, that could almost be enough to create the context. And this brings up a point of like health literacy, where you have two patients where one of them, all you have to do is tell them the context of what they're doing, right? Like relating it to whatever they want to be able to do. And that's going to be enough to put them back into their own like mental environment of like, I can see the road to why what I'm doing right now has to do with what I want to do. And then you have another patient who can't make that connection. And so now you've further removed them from their context. They're in your environment. And so I think, James, what you're saying, and also Derek, what you're saying too, like bringing it back to putting them back into their own context sooner and tying it to their function sooner, maybe making different decisions about what interventions we use that can be more relatable earlier on. So that really kind of like blew my mind just now, actually.
I could see this this getting portrayed or misconstrued in a light of like the overly functional coaches or trainers that want to make all movement quote unquote functional, because this is talking about bringing it back to function. So have you thought about that, James, of like, where is that line drawn in the sand between making it context dependent and based off of like the end goals, but not making it so like at some point you need to like isolate variables and train certain like variables. What are your thoughts on that? Because I feel like it can swing in very far in one direction as well.
Yeah, it's funny. I was actually just about to touch on that, because part of the part of ecological dynamics, or that framework of motor learning, has to do with information being the thing that influences like self-organization and movement. All that means is like, you know, the information we're perceiving from our senses has a lot of, or dictates, and in terms of also the context or the information we're receiving from the environment, the task, is going to influence what movement self-organizes. Going back to your question, right? How does that influence like training, like, you know, being misconstrued as like, or being too functional? And I think that has to, this is where there's opportunity to better understand how our interventions like actually create change. And it's something that part of the reason I'm really I really like this topic, or this like this framework, is because it shifts it from like, if you understand that like what we do in terms of movement or interventions, a lot of it has to do with providing or getting somebody to learn or provide or give them more information about how they're moving, and help them better establish like the ability for them to see or perceive that information. All that means is like, you know, when you look at it from the context of their environment, when you get them to do an exercise, it allows them to better understand. And if you do this well as a therapist, like relating it to the thing that you want to get better at. So if you better understand what they want to get better at, and then you tailor the intervention around how certain exercises might contribute, but in a very meaningful way, not in just like, oh, it looks like this exercise, so it's going to get you better at that. It usually isn't that simple. And we know this from like specificity standpoint, right? But in terms of one, doing the actual thing, and two, better understanding, this is where I think it's interesting. Your biomechanics actually helps you be better at this, in my opinion, because we understand like load specificity, like direction of load and force. And if we better understand those concepts, when we look at the functional tasks that they want to get better at, we're actually going to be better able to make things more functional. Not being and if we understand specificity, then we really know that it's not functional from the sense of like, it looks like the thing they want to get better at. It's more so it's functional because we have a better understanding as clinicians, like direction of load, force vectors. We're better able to relate it to the actual functional task dynamics of the thing they want to get better at. It's the question of whether or not we get to that sooner than later. So we base our assessment around that idea or that framework. We're going to be better able to create interventions that are specific or functional, based on those like sound biomechanical principles, but as well take into consideration how the environment might influence the expression of those biomechanics per se. So there's like a reconciliation there that there's definitely opportunity for. But this framework actually, to me, it kind of like ties it all in. It makes you be more functional in that sense. Does that make sense? I don't know if that answered the question or not.
Yeah, that was perfect.
So I was kind of wondering what your, James, I guess, after reading this, they didn't touch on it at all in terms of contextual interference. So like, you know, with learning and motor learning, that's a huge piece to actually programming, right? Is any sort of practice, we have to take them out of a context, or we have to actually create some sort of other variable so people can learn. So if we have them come in the clinic, maybe it is somewhat functional. We're taking them out of the environment. We're interfering with that. So when they go back to their environment, potentially they've learned, you know, a new strategy or whatever it may be to know how to be functional or specific, whatever you want to say. So I just kind of wondering what everybody's thoughts were on that, because they don't touch on that at all.
Yeah, I think that's going to be very specific to where they are in that process. And it's going to be very specific with around the context of what they're actually learning. Because if you think about it, what like motor learning, like in a broad sense, is, you know, it's the umbrella, right? But it applies to the specific thing, and it could be specific to like an exercise, if that makes sense. Now they might be impaired to the point where they can't do the thing they want to get better at. Like they can't run because they don't have an ankle because it's broken and it's in a cast. But like the idea is like, well, what can we still learn? So using the principles of motor learning, like we can apply specific to exercises that allow them to better understand that. I think it changes the approach of coaching from being very prescriptive to being and kind of shifting away from that and allowing self-exploration. I think that's what ecological dynamics is all about. When you make that shift in regards to how you coach, and again, it goes back to the language you use around facilitating self-exploration, it allows patients to, in my experience, from applying it so far, I've also applied this like as a coach prior to starting PT school, but it shifts your coaching to, you know, and centers it around the patient or the individual, and putting more emphasis on what they're experiencing with that exercise and helping them better understand what information they're getting from that exercise. So that there's a mutual conversation, or there's a conversation between you and the patient on how it could relate to the thing they want to get better at, and then allowing them to be part of that process. So going back to your question, contextual interference, I think what I meant around that was, you can better facilitate that contextual interference around a specific exercise as long as you both understand like the direction you're going. If that makes sense, kind of, because you're talking about like how do we facilitate more learning, right? You want more contextual interference to like make that stick more. It all depends on the exercise or intervention you choose and whether or not you understand it well enough to facilitate that contextual interference. And I think it's going to be more effective if it's more relatable or specific to the actual thing that they need to get better at, instead of it being some arbitrary exercise that you're supposed to do for this condition, if that makes sense.
I also like the part closer to the end where they have those like 6 domains of laying out like those theoretical foundations for this better approach. And I think it was domain 3 and domain 4 where it's talking about multiple task solutions and the role of variability. And in my head, it seems way more freeing to you, the clinician or the student, and to the patient of like, kind of as you said, it's an exploration of trying to achieve a task. And it's not this like a rigid, you have to complete it in this one particular way. And like James, you and I had talked about this on the phone with like the way our orthopedic professors teach certain movements, or even neuro, and they talk about it in this paper as well. But it's so like one size fits all, and it's not, and this goes back to language as well. If you're allowing the patient to realize like there's not really one good or bad way to solve what we're trying to do, like we're just trying to see all these different pathways and see what is like efficient or comfortable for you in the moment. And I really like that they laid those two out. And I actually sent this paper to my neuro professor to see what her thoughts were, because I think this did a good job kind of harping on both the like neuro and the ortho issues of kind of the current model. But yeah, I liked those 2 domains in particular, 3 and 4.
Yeah, I'd love actually some input from the other students here, because something that so when you take into consideration this framework and this idea of self-exploration, right? And how it influences coaching in terms of understanding that there's no one size fits all, understanding that there's no one way to do an exercise, and understanding that there's multiple ways that can produce a particular outcome regarding like muscle activity, right? So you can be successful in a certain task, but it may not be through the same motion, same particular pattern of activity. And kind of what Chris was mentioning, like that contradiction of like, well, if we understand this is how people learn, and this is something that's really kind of been researched, why is it that we're taught exercise, or we're taught to teach exercises like this is how you do it? When you want to do serratus slides, you have to do this, and you have to do it this way. You have, it's very prescriptive. And I think this is what this framework tries to take you it tries to kind of shift you away from that way of coaching. But has anybody else experienced that in like, we had like half a semester of TheraX at Columbia. So I'm curious how like other programs, like if it's similar in my experience, or if maybe not, maybe other programs are actually applying some of this approach and less prescriptive.
Oh yeah, I mean, for me, I'm a first year, so we had a TheraX class last fall semester, and it was very much that prescriptive way. I think that like kind of like the paper here that like preached it until it was blue in the face of like the environment has to be taken into account, and the person and the environment has to be like one unit. And one thing I thought of a lot was like those pictures of basketball players with like extreme knee valgus, or like, stuff like that, where like, I mean, as a PT student, you're like, oh my gosh, they're going to explode. And like, what's going on? But like, they're something along the lines of like, the paper said that person in the context or environment, the movement that they create kind of, which sometimes may contradict our biases or our prescriptive, ways of thinking in PT school. That's the best movement solution that their body has come up with for that particular context. So like, I don't know, like we never really talk about that in school yet. I mean, I'm still in first year. I doubt we will, but like that kind of stuff is interesting where like, you know, we see movements or like anatomical bodies in certain anatomical positions that like they contradict our prescriptive way of thinking in school right now.
Well, again, I think it goes back to like we're uncomfortable with uncertainty. We have to have this linear approach because if we see X, we need to be able to do these specific things to get to Y. You know what I mean? So when we have uncertainty and we realize that, you know, we can't really define what optimal is. And I know they use the cerebral palsy patients quite a bit where, I mean, their movement patterns are totally different than somebody we would look at and say is normal. So, I mean, can we really look at that patient and say that, you know, your movement pattern is obsolete? Or is it the most efficient movement pattern that that person has currently? And we need to learn how to navigate within that instead of completely trying to change things and tell them that, you know, this isn't optimal and this is what I need you to be doing. It's the same in any sport task or anything else we see in clinic. I think we get too caught up in, you know, we need this perfect movement or we need this certain amount of range of motion instead of giving them that variability and allowing them to just kind of explore that movement on their own, like we were already talking about, and giving them options of, you know, what they can do to either improve what we're looking for overall or to, you know, maybe explore a different movement pattern that would be more efficient. But again, I think the paper talked about that, you know, at the end of the day, looking at movement specifically and trying to change that shouldn't be the goal. You know, it could be an outcome that we see, but I think there's other aspects that we need to pay attention to throughout our rehab journey as well. You know, giving people specific exercises or trying to force something upon them, even after explaining that this may be what they need to get better. You know, if that person doesn't want to do those things or that's not what they want, you know, we have to reframe what we're looking at and why, you know, we want to work with this patient. I think we get too caught up in trying to get people to buy in, but if it's really that hard to get somebody to buy in, are we just pushing our own narratives and our own bias onto people instead of really allowing that shared decision making?
That's a really good point. And I think it actually ties in exactly with like why this is such a valuable framework, because if we're trying to constantly push buy-in to like your method, right, it kind of takes the patient out of it. It's like, all right, you're coming to see me to get help for something you want to get better at, but I'm going to try and get you to buy into my method of getting you better at this. When if you right off the bat are better at individualizing your method to but not really your method, but understanding that like they understand the way you're going to approach solving this issue is by better understanding what they need versus like, this is what you have to do. I think that also changes the language you use. And I think that's a very good point and something I always think about too. Like, am I just trying to push like my biases, my preferences, or am I like really taking the time to better understand like how I can relate or better understand what they need? And if they can't articulate it, am I spending more time helping them do that rather than trying to make assumptions and just trying to figure it out myself and without getting them involved? And I think that's something I've been trying to get better at, especially after my first clinical experience.
I think though, like on the other side of that, I mean, how far do we go in terms of allowing the patient? I mean, I think every single person here, there's a reason why we are all in the same room right now, and we are considerate of the patient's influence on the entire treatment plan. But on that same point, they've shown up, right? They've determined that this is valuable for them to be in front of you, in front of someone who is in their minds going to be more qualified than themselves to help themselves. And James, I like that question that you were talking about earlier, what would you like to get better at? Because I think that's an interesting question in PT in that I don't think a lot of therapists start with that question, because it's usually about, well, why are you here versus what would you like to get better at? And I think that alone creates the context of, okay, well, now they're trusting you a little bit more because you've given them an opportunity to tell you what it is that they want, versus telling them, okay, well, I have this script and it says you have subacromial impingement, and I'm going to ask you some questions and then treat you as I see fit within maybe some options that you can choose from.
Yeah, because that's a good point, and I appreciate you bringing that up, because it reminds me, like, if you get to that soon, I tend to ask that just because it was a tendency I had that kind of was left over from
It's a great,
sorry, what did you say?
I said it's a great question. I like it. It really, I mean, it's so simple, but it really is something where you're giving someone an option. Like, I am here to help you be optimized as a human being. Like, what do you want versus like, what do you need? Because I know what you need, but you're going to tell me what.
Yeah, because like also as a trainer, as a strength coach prior to school, like usually people came to try and get better. They're in the process of trying to get better at something. And when somebody comes to you injured, I don't think that's going to change. Like, yeah, I think it's just like you're too focused on like the injury or the diagnoses. Sometimes you forget like there's also other things they might have been working at. And I think if we also remind them of that, and then try and also, you do have to ask too, I feel like, because then they're overly focused on their injury. And I feel like sometimes a session can get too tailored to the injury, which is, well, obviously they're there to address. But I think the better you're able to navigate that towards or relating the basis of your interaction with this patient around, hey, I'm here to help you still work on that thing that you think you can't do anymore. Obviously, we're going to address this issue at the moment, but we're going to try our best to see how we can tie in meaningful goals with you. So I think the better, it just goes back to also understanding goals in your patients and whatnot. But yeah, it's like kind of what do you want to get better at? What were you getting better at that maybe you're not at the moment, but maybe we can kind of tailor what we're doing to still get you back on track.
Well, and it comes back to like changing our concept of what disability is. Like, it's not just that, oh, like for example, my dad had rotator cuff surgery way back, like, and he didn't quite get rehab like very well. So he changed his main stroke in swimming from freestyle to breaststroke. And in tennis, he no longer hit the topspin single hand backhand. But he can still play, and like he can participate in both sports. So like I would deem him full functioning unless he, as the patient, would say like, hey, I would really like to get back to freestyle swimming, or I'd like to rip a topspin backhand down the line again. Then it's like, all right, let's work on that. But if he's still able to do everything he wants to do in the context of the environment and he's happy with it, then like, why create another problem to solve, right?
And it almost does kind of go back to what we were talking about earlier with context, and that question alone takes it from what the medical model deems to be like, in some ways, you're broken, right? Like, you're going to physical therapy because you have something that needs to be fixed. But instead of doing that, you have now changed the context of what physical therapy is to what would you like to get better at? Normalizes the fact that every single person who has a body will have pain at some point, and getting away from pain does not equal broken, right? Like, dysfunction, whatever, pathology doesn't mean broken. It means one area of the system is taking over for another area, or something to that effect. And if we're totally changing that context from saying you're not broken, what would you like to get better at? Okay, you have pain. You would like to not have pain. Great. That's a good start.
Going back to the paper too, like, and in terms of like the framework of ecological dynamics, and it mentioned in the paper, I don't know if anybody caught it too, the concept of affordances. So the idea that, affordances, opportunities for action in your environment, and that these affordances are predicated, are really highly influenced by your specific, what they call like action capabilities or effectivities. So the idea being what you perceive for an opportunity to act or do or move is dependent on your capacities, you can consider your individual constraints, right? And so I think better understanding, it goes back to, well, this person is like functioning, like, and they're doing what they want to do, or like specific to like the case of what you mentioned, Ben, your dad, right? If we better understand, like if we dive a little deeper into that and we better understand, well, what are the task demands of the thing they want to get better at? They're functioning, they're doing the thing they want to do, but there's a layer deeper to that. I actually happened to play college tennis, so I love that example, because you need a certain amount of external rotation, certain amount of strength to be able to do a top spin backhand, and a lot of it is dictated on how well you're able to follow through. Anyway, I'm getting specific, but I think it's a really good example because the better you understand the task dynamics of the thing they want to get better at, the better you're going to be able to apply your biomechanical knowledge to create interventions actually specific to getting them to tolerate load, stress, specific to the ranges necessary for the task. So then, going back to the idea of like affordances, you might tell them, oh, you want to do topspin backhand? You just have to be able to get a little bit more, lift on the racket, right? But what if they don't have the abduction, right? They're not going to be able to perceive that opportunity to act on a fast coming ball if they don't have the actual capability to actually do the thing they want to do. So then the better you understand that, the better. So now all of a sudden lateral raises become a little bit more functional. That makes, you see what I mean? Like how you frame your intervention is what allows you to make that exercise meaningful to the patient. And I think that's what's so valuable and like powerful about this framework, because it actually helps tie in like biomechanical practice and like understanding of like mechanics into like, all right, how do we balance that with like the psychosocial / like, the environmental task demands, and how do we kind of put that all together? Like it allows you to better frame your interventions and the conversations. And I think the biggest piece is like the language. It kind of goes back to the language of helping them better understand what it is you're trying to do. And so going back to like the concept of affordances, right, is very interesting because like when you think about like your action capabilities influence your ability to see opportunities for action. The thing is, you might have those action capabilities, but then you don't see it specific when you're actually doing the thing. And so it's interesting because then now you understand, well, then the more exercise I do, that's not going to help. I actually have to see you do the thing that you want to do. So it also helps you be more specific and helps you get to that point sooner than later. Because if you don't understand that, you're just going to get stuck on it. Well, let's look for another exercise. Did you get better yet? It's like, no, maybe they just needed to do the thing more. So then I think this framework has helped me kind of conceptualize that more. But yeah, I might have went on a tangent there. So I don't know if anybody has any thoughts on that.
Well, I think patient education is huge in that opportunity as well. I mean, I think oftentimes media and other healthcare providers, especially if it's, a post-op procedure. I know I had labrum surgery from a dislocation, and the concern was, never do anything overhead again, essentially, because you're at risk of dislocating. And I mean, for the longest time, for me personally, I mean, that was a fear where if I did anything overhead, like the chances of me re-injuring were high. But then, violating those expectations and kind of relearning how to do those movements and just kind of easing into them instead of expecting that I can go right back to where I was with specific tasks and loads, and just kind of dabbling in it to see, okay, I can do this. And then over an extended period of time, it was, I really don't have anything to fear with this movement. But I do think, again, going back to that linear model, that it's, well, you did this, I fixed it, but if you do that again, there's a likelihood that you'll have the same issue. And I think with more of the biomedical model or that anatomical assessment of things, that's kind of where we get stuck. And then patients have this expectation that, well, if I want to do this again because I did it at one point, I should be able to pick, let's say a racket up and do those movements again right out of the gate, instead of understanding that, there is going to be a time where we have to maybe retrain that movement or maybe build a capacity so you can do those things effectively, instead of just throwing you to the wolves and expecting you to be able to perform at the highest level that you were before. I think we see that a lot with people who, ran back in high school or college, haven't run in years, and decide, oh, well, I can run again because, I used to run 5 miles a day, and now I try and run, 5 miles a day, and my body feels like it's falling apart.
Yeah, that's definitely like education, right? So I think that's also another opportunity to kind of talk about like what it is you're actually educating to, and thinking about like, well, what are the what kind of information are you focusing on in regards to like what you're trying to help somebody better understand. And I think having this framework shifts that conversation of educating somebody on what they should or shouldn't do to rather educating them on how to better explore the movements that they're fearful of. So it kind of shifts the perspective a little bit too, like spending the education on like less of me directly like transmitting specific information to more so like helping them better understand some information that they're perceiving. So the education being on like how to better perceive what they're feeling. And I think that's what we do and kind of couple exercise for like technically like the way I like to, or not technically, the way I like to look at exercise or interventions or movement-based interventions is to help somebody better understand or help them better perceive what it is that they're feeling when they move. And if you look at it from that framework, like I'm not doing it to get them better at something else. Like it's more so I'm doing this exercise because I see it's a good entry point for helping them better perceive tension, better perceive like movement in a particular range of motion, better perceive like force production. And then always tying it back to, all right, let's see, can you see if you can replicate that to this, like, and then changing it there. So it changes it from like, do it this specific way to like, hey, tell me what you feel when you do this. And then let's shift it a little bit. Let's change some of the task constraints and see how that changes the information you're perceiving. So if you frame your treatment around that, you're helping them get better at reflecting on the stuff that they're perceiving, if that makes sense, rather than telling them what's supposed to do. So I think in your case, in regards to like education, right? All of a sudden now you're better able to educate somebody on the stuff that they're feeling themselves, like within their own body, rather than like an arbitrary rule, don't ever go overhead. Like I think it's makes it more specific to the individual, makes it more, gives them more control in that sense too. So it goes back to that idea of like the language you use, like how that's why I really like this framework, because it doesn't just talk about like how you should intervene, but rather how you should look at how you talk to somebody to fit. And when they relate it to like the ICF model, I love that, because I really liked the ICF model. And I really, when I first got into school, I was like, oh, this is amazing. Yeah, I love, like, it's not unidirectional. It shows how everything is interacting. But I just saw that disconnect between what we were being taught in terms of how to actually work with somebody and then this model. So it just didn't make sense. Like we were learning such a prescriptive model, but then like this framework is what we're being taught. But yeah, I agree in terms of education. There's definitely a lot of opportunity. And I think this framework definitely gave me the tools or like the mindset to better approach it. I wanted to actually, oh, sorry.
Does happen a lot. Sorry. No, I was just going to say, I feel like that disconnect does happen a lot in school where like, so I just went through in the fall cardiopulm, and cardiopulmonary rehab is so holistic in that you have this entire human approach of like optimizing function and exercise, nutrition, lifestyle changes, stress management. And I'm like, this is a really nice musculoskeletal framework. Where was that last year? And it's funny because like it is taught by the same exact people who also teach some of those courses, who also are practicing physical therapists. I'm like, how do we not see that that should be the model both ways?
And just another
exactly. And go ahead, Adrian.
Just a quick comment. Another obstacle I think that we face after being in this controlled education environment where we're learning about the ICF model and doing these hypothetical case studies, and then we go into our clinical education experiences, and it's kind of like luck of the draw. Who are you matched with for your clinical instructor? Were they given the same value and education on ICF? And so much of our application is often structured around that experience when we're in the clinic. I know that's something that definitely I was challenged by in my clinical rotation in the fall, but yeah, it's super difficult when it comes to translating what the ICF model means in application.
And just a thought too, regarding how we were taught to like specific diagnoses, conditions, diseases and whatnot. I think if you approach and have this framework of like how, first of all, this is more of like, I think this framework really ties in very well with like how you interact with somebody. And I think it's one of the biggest like limiting factors to somebody being comfortable getting into clinic. Like, yeah, you could be very smart, but if you're having issues like talking to a person in front of you, it just makes it really tough to help you be more comfortable in having that conversation, which they can perceive you being uncomfortable. So to me, like, if you understand, like, all right, first of all, like different conditions are going to present differently. Not every exercise has to be taught a certain way. You know, there's no one size fits all. Anyway, I think the idea of if we understood like, all right, we're going to make sure that the way we approach a particular patient is we're going to be listen to them. We're going to try and better understand what it is that you want to get better at, and then take a look at like maybe what they're coming in for and see how we can better understand that condition or impairment from within the context of everything else. It would make things much easier. But I feel like when we're taught like in ortho, all the conditions, right, all the impairments, diseases, injuries, it's like you're so fixated on that thing. So yes, we have to learn it. But I think if it was like focused more so within the context of like these, if I would have been more receptive to it if it was taught like these are the things you need to look out for. And so these cases like that we're going to go over, like, yes, you kind of have an idea of what you're looking at, but still focus on what we were talking about from like kind of look at it from the whole picture. Like, and don't be, and from intervention wise, like, don't think like this is the, like, you have to be able to better tie in like how that relates to the bigger picture. And I just think that got lost a little bit when we were being very specific to what we were learning. But then again, that could be like, you just kind of need to. I also don't know. That was just a reflection I had. So I don't know if anybody experienced that as well, but I know like obviously we have a lot of information to get through in school. So there's not the time, but you're right. I also noticed that disconnect, like did you notice in cardiopulm, like this would have been nice to like learn that in ortho, this perspective or this framework. Still learning the same information, maybe the approach would have been better if it was more holistic in that sense.
Well, I know one of the areas that I see in chiropractic that I have an issue with is that there's this, in certain classes, not all of them, but there's this idea that we can almost treat any condition that comes into our office, and that, you know, we always have this like clinician mindset where they come in with a problem and I have a cure to almost fix this. And of course, with chiropractic, it's, you know, the adjustment more so than not. But I do think, and Geronimo and I had this conversation of knowing when somebody needs you to be a clinician and when somebody needs you to be more of like a coach for them. And being able, like you said, to have those difficult conversations and figure out who the person is in front of you. Because, you know, if they come in, let's say with low back pain, and they don't exercise and they're a smoker and things like that, you know, we can have the conversation with that person about, you know, how important it would be if they did do exercise or they did stop smoking. But at the end of the day, it's not up to me to tell them what's right and what's wrong. You know, I can give them a framework and make recommendations and give them an idea of what could possibly help. But at the end of the day, if that person's not open to making that commitment or isn't open to doing the things that I've laid out in front of them, you know, am I the best person for them at that time? And do I need to get somebody else to maybe step in and help them? I know Michael Reyes talked about that where, you know, he doesn't do any kind of manual treatment. So if he has somebody that comes in and wants more of a manual approach, you know, him being patient-centered, it's, you know, I know what I'm willing to offer you and I've laid that out for you. But because there's somewhat of a disconnect between you and I, like, I'm more than happy to find you somebody that can meet you where you're at. And I think that's another important part with this conversation is, you know, being able to kind of self-reflect and know that, you know, maybe what we have to offer isn't best for this person at this time as well. And I think that's a hard thing to look at as well.
You know, that's so interesting because that reminds me of one of the topics we touched on in school, and I'm curious to hear if anybody else had the same experience. But we talked about motivational interviewing in one of our professional leadership classes, and how I just thought that was so valuable in terms of like, we're like, you know, outside of PT, like instead of being so focused on like the exercise assessment and intervention, like, well, all right, let's talk about behaviors. How do we get people to change behaviors, because ultimately that's really how where we can make the biggest impact, in my opinion. Like if we better understand what behaviors drive someone's interaction in their environment, and the better we are able to understand that, the sooner we're going to be able to find an entry point for trying to change those behaviors. But at the same time, like you said, Derek, like if they're not ready, like how do we have the tools to actually create those changes in behavior? Or first of all, do we have the tools or the ability or capacity to help them understand that they need to change those behaviors? And if they do, like how does that relate to maybe some of their goals? And I think motivational interviewing was one of the key pieces for me in school. It influenced like how I approached my interactions with patients, like 1,000%. It was because I wasn't so fixated on like, you need to do these exercises. It was more so like, well, all right, let me better understand your current behaviors, see if there's anything that you may need that we can kind of work with to try to better help you in going the right direction, and have a conversation about how maybe we can start, at least begin that process. And if you don't have those tools, if you understand, you're able to assess somebody and like, oh, maybe I don't have the tools to actually address that behavior, maybe then you can reflect on it. They're more receptive to maybe that recommendation if you had the time to have that conversation to begin with, rather than like, you need to change this, I'm going to refer you out. Like I feel like I've seen that, and it's like you didn't even talk to them. Like even if you can't help them, like just by talking to them and having that ability to engage with them, it's going to help them better understand what they're dealing with. And ultimately we can do that. That's a huge help. That can really influence outcomes anyway, even if you don't have the tools, helping them move as a whole, but helping them better understand their current place, their current like limitations or like current situation. It's going to help them better be more receptive to like change. And I think, yeah, that's a big opportunity that I think it could definitely be emphasized a little more in school.
I'm curious to hear y'all's thoughts on, there was this section on best practice, the role of evidence and theory. And I feel like they made a strong argument for why theory needs to always be like an underlying thing when using best practice or being a clinician. And I think maybe it's just left a bad taste in my mouth, because in like our orthopedic class, I'll ask a professor like, why are we doing this? Or he'll always have the caveat of like, well, this is based off a theory. And that's almost like a scapegoat for like doing something that's not justified or not proven. So I was curious if y'all had any thoughts on that part of the paper, or like where you find a theory and like the big picture of things.
I mean, I kind of feel like I have the opposite opinion in some ways. Like I for sure have experienced what you're talking about, Chris, but I also think I've experienced the other side of the spectrum where it's, we can't do anything unless we have evidence. And so I think finding that, and especially, we don't have I was having this conversation yesterday. So my program does not have a Therex class. It's wrapped into our musculoskeletal class, and it really is like an afterthought. And I understand that in a lot of ways, like it's an insurmountable topic and that you really can't cover everything, but it was not really part of our education at all. And so the things that we did learn that I could, tease out are things that very much are covered in the literature of like, for example, like decline squatting, or things that like, for one specific pathology, I can use this thing. And so then you get into this very narrowed view of, I'm a new clinician and I have this one tool because in school I had evidence to support this one tool, but I don't have the theory more broadly to think about, well, why did this tool work? So I kind of go back and forth on that. And I do think we need both. It's a fine balance of figuring out how to use them. And I think sometimes the evidence matters a lot, and then sometimes the theory matters a lot. And I think it's patient.
What are your thoughts on the differentiation between like principles of understanding and like a theory? Because I think principles are more relevant, maybe if we're talking about it from like a Therex perspective, than like theories.
Yeah, I guess I see the difference. But do we get to principles by theory? So theory drives principles, and then principles drive how we make decisions, and then we have evidence to back it up, hopefully.
I think keeping in mind that like they all influence each other too, especially like I kind of agree with Alex as well. And actually going back to the paper, one of the things that they mentioned, like, so I think there's a line here. Let me see if I can find it. When you, let me see. The theory, I think looking at it from the perspective of theory, like it's not so much looking at the theory of like why it's happening, rather the theory of how it can be applied. I think there's a difference there. Like there's theory of explaining the physiological mechanism behind an intervention or something like that versus the theory of application of pedagogy, teaching something. I think that's where this is more relevant in terms of theory, because from a ecological dynamics perspective, it has a lot more influence on how you go about coaching and teaching somebody and getting them to learn, rather than like trying to explain the theory behind the intervention itself, if that makes sense. I think there's a difference there. And that's what I think is where the true value lies. Because ultimately, like, we're not going to know the physiological understanding of everything we do. And there's going to be, and like even research is limited in that sense. Because one of the things that they mentioned in the paper was like, well, you know, even like RCTs can't really account for every single possible interaction or like or condition or situation or scenario. So like, what if we were encountered with that in practice? And I think just having a theory or framework to at least base your application on, or exploration, you see, I think it changes, like exploration of different things allows you to fine tune it to the individual, rather than trying to only work off what's like been proved. Because ultimately, like, not every, like, you're never going to find like the true answer like all the time in research. But again, it's not like you have to, it's either you do all, you're only evidence based or you're theory based. It's more like better understanding how they relate. And yeah, I don't know. I don't know if anybody has any thoughts on that, or if maybe I'm not making sense, but that was something that was kind of like coming to mind as I was reading this part.
What I'll say is, just from a coaching perspective, like the use of theory, I guess, just helps you get started, like not feel paralyzed, like I don't know what to do here. And then you have like your direct interaction with your client or your patient or whatever it is. And then you take that, experience, and then that's your evidence. And then you also take like applied research, and you kind of, like, all the things they're not independent. They all kind of sit in the same house, right? Because theory fuels our practice, and then our practice fuels the theory, and it's continually evolving, right? So it's just kind of like looking at it as those things aren't independent, and you don't have to just use the theory, just kind of like what James said, or just use evidence, because like I said, they all feed into each other.
I think if anybody follows Rob Gray from the Perception Action podcast, I highly recommend, because he really talks about a lot of these topics. But the one thing I really appreciate about some of his journal clubs and kind of like gatherings are he gets coaches involved. And I think one of the biggest things that in motor learning research and a lot of the big names within that field, like, they really push for getting coaches involved, because ultimately coaches are the ones working with athletes and teaching people. And then the researchers acknowledge that they're limited in their ability to better understand how things are applied. I think it just comes back to that, that interaction of like, are we, it's something that we feel each other, right? The coaches are doing things and exploring things, but there's also things that they, from a theoretical standpoint, like, it can't be applied practically. And so, but if you just solely base it on like research, like, and you don't have that conversation or interaction, you're never really going to be able to understand or like come to a good point where like there's a good balance. And I think that balance comes from like having those conversations, not just, and I think that conversation, you can have it with yourself too. And what I mean by that is like, understand the theory, understand the evidence, and then it comes back to patient preferences too. How does that tie into what you decide to choose? It's just kind of like that dynamic interaction, just better understanding how to adjust based on the person in front of you, rather than just like focusing on what you understand from like emphasizing too much on one of the pillars, and kind of shifting away, and just, yeah, being flexible, I guess. actually, sorry, one last point. I really, that specific to this point, I really liked how they talked about this, because, you know, a lot of modal learning research is theory based, right? But then it's taking a look at, well, how can we best update this and how can we best apply this so we're at least going in the right direction. And that's what I really appreciate about modal learning theory, at least some of it, especially specifically the ecological dynamics framework, because it's meant to replace, it was literally created as a replacement for some of the information processing theories, where, you know, that analogy of like the brain is like a computer, that's kind of like Schmidt's like modal learning schema theory. Like some of the, it's trying to update some of these like frameworks that are so heavily rooted in our rehab practice. And that's where a lot of the prescriptive style of coaching and teaching comes from. This idea of like, you have to process all this information and like in your brain, and there's a program in your brain and a pattern in your brain that you need to like develop and construct, and then you're able to spit it out. Whereas ecological dynamics came and said, doesn't work that way. We move too fast. The information we're picking up is coming too quickly. We need to be able to like react sooner. So how can we create a framework that better applies to how we actually move in the real world? And that's where we're looking, and that's why this was created. And I think I really appreciate this particular paper and how it's like taking a look at how is it applied within the context of rehab, because it just helps change your perspective. And that's why I really appreciate how, yes, there's a lot of theory involved, but as long as we're able to reflect on theory and relate it to practice and seeing if there's opportunity for change and seeing how it's evolved over time, I would say it's more a reliable theory to rely on, rather than a framework of thinking that's based from the 1940s that hasn't changed since. And it's like you question, well, what's been updated since? Like, so I think this is one of the more newer frameworks to keep in mind and to look out for. And it's definitely blowing up in the coaching world, especially to the work of like Nick Winkelman, a lot of the work being put out by like Rob Gray and a lot of other like big names in the field. But I think that's why I wanted to talk about this paper, but that's something I want to touch on.
Well, I think that's an issue we see a lot with like these weekend courses, is that they give you like this framework that, you know, this is the cause of the problem. If you do these things, this will fix it. And we have all of these different, you know, gurus and quick fix approaches at Logan University. You know, it's like DNS, where everything, it can revert back to, you know, your infancy and how you didn't move as a baby, and that explains everything that you do. And I think that, you know, if we get caught up in those specifics and only looking at people in that way, that we do them a disservice by not addressing them as a whole person, giving them options and really figuring out, you know, like you said earlier, you know, what do you want to get better at? And then also reflecting and being able to go, can I give that person what they're looking for? Like, do I have the capability of doing that for them? And I think those two things are huge, instead of, you know, listening to what somebody has to say, but you already know what you're going to tell them and do anyway. So you're not actually engaging in dialogue. It's more of a, well, I'm just listening so I can respond and tell you what we're going to do. And I think that tends to be how we see healthcare professionals, where it's not a back and forth. It's, I'm just going to sit here while you kind of go on about your business, and then I'm going to tell you what we're going to do anyway.
And that's why I love this framework too, because if you're familiar with it, it's this framework tries to get you away from that as much as possible, because it puts emphasis back to the individual. Everything is based on what the individual is perceiving, what the environment they're moving in, what are their capacities for movement, their individual constraints, and then looking at it in relation to like environmental and task demands. And so ultimately, you don't know any of that unless you talk to them, because like you just met them, right? And so keeping that in mind, it kind of humbles you in a sense, like I kind of have to listen to really understand this person. And if I don't, then I'm just making stuff up. I'm just trying to get them to like buy into what my bias is. And to me, it almost like lifts a weight off your shoulders. Like you kind of don't have to know everything, right? It's kind of like, hey, I'm going to have a conversation with you. I don't know what's going on, but you're going to help me. And my experience working with athletes I have in the past, for example, I worked with a ballet performer, and I'm like, I never worked with a ballet performer before, but hey, you're going to tell me what you need to get better at, and you're going to help me better understand that, and then we're going to work together to kind of put something together for you. And I think that just right there, I didn't have to know everything about ballet. Rather, I simply asked the right questions of, well, what do you want to get better at? What do you think, given your experience, like, can you tell me what's limiting you? And if you don't know, I have some, based on what you're showing me, and this goes back to the mechanics side, where we're actually looking at task dynamics from a load perspective or force perspective, helps you better understand like the demands of the task. So you can at least have that conversation of like, here's what you're showing me. From what I understand movement wise, like these are the things you want to get to, but these are the factors that might be influencing that. Let's take a look at that. Instead of like, I know what the answer is, it's more of like an exploration. So there's exploration within the interaction between you and the patient. There's interaction between the patient and the exercise. And I think just facilitating exploration as a whole, but like within the context of how you're going to get that person better within the thing that they want to get better at, it just helps you drive or facilitate that conversation in a better direction, in my opinion. So yeah, I think that's why this framework, it just made sense, like, but it's just not really emphasized as much, or something that, it's funny, it's being taught more so or spoken a lot more in the coaching side. A lot of coaches are really getting into like constraints-led approach and like ecological dynamics, but then in the rehab side, like in movement science, we have like one class on it. We touch on it just briefly, and it's weird. It's like they're still teaching information processing theory, and it just doesn't make sense to me. And like, if there's so much more coming out on like it not being that, that's where I see the discrepancy. Especially if we're taught a holistic model like the ICF. It just there's a lot of conflict there, and that's why I love like touching on this. But yeah.
Did you ever have discussions with your professors or with your like CI about this and some of them like mismatch?
I definitely had to navigate it like carefully, because I wasn't going to be like, well, have you heard about ecological dynamics? And I've done that in the past, but I can tell like there's my professor in particular, she touched on ecological psychology, which is part of the roots of ecological dynamics. So ecological dynamics is just like the blending of dynamic systems theory and ecological psychology from James J. Gibson, yada, yada, yada. It was like literally one line, one sentence, one slide, and then we moved on. We went over a bunch of theories, and then we went right into like other topics, kind of talking about redundancy and whatever. So when I bring it up to my professor, it was more so I understood that like, oh yeah, these are just theories, whatever. But it wasn't really touched on. Like, I can tell that she was more so focused on the intervention side of things. And I didn't think I could get a good conversation around like this framework, because a lot of what she taught was from the schema theory, some of the old frameworks. And then regarding my CI that I just had, I definitely didn't talk about it, because he operated completely on like, oh, your glutes weak, we're gonna do a glute. Like I automatically knew like motor learning wasn't really something that he said it straight up, because I mentioned in one of my like pre-affiliation questionnaires, like this is what I'm interested in, and he's like, oh yeah, this stuff's cool and all, but so I try to do it more so I try to apply it in my practice, and when he observed, we were able to have conversations, but I can tell like it's not something I've had very good success on if they're not really interested in, especially if they're purely orthopedic practitioners, because orthopedics tends to be very like prescriptive, like this is how it's supposed to be and you're supposed to do it this way. But that's been my experience.
Going off of that, you had expressed an interest in more of the neuro side of things, I think because it's a little less prescriptive, but even in the paper they were talking about like BOBAF and NDT and kind of the issues with those models from like a neurological rehab perspective. So do you think there's still like the neuro side is a little bit more open to some of these concepts, or like why do you shift towards an interest in the neurological rehab side of things?
Yeah, I definitely think they're more open to it because they're working with individuals who have an impaired nervous system. And so like you can't be prescriptive because they don't even have control of their own bodies, right? So it's like that approach isn't going to work. And the best thing you can do is help them better navigate the thing they want to get better at. So that's why like a lot of stroke rehab is very like task specific. They talk about task specific training. And so I definitely think they're more open to it. And that's why I was interested. But it's just interesting how like even there within like the neuro setting and practice, there's still some emphasis on like older frameworks. But in terms of who would be more open to changing, I think like definitely the neuro side, because that's their whole practice is based on exploration, like it's specificity. And I'm interested in like actually applying these concepts and approaches with particular patients, kind of having my orthopedic background, sports background, like going back to like what Alex was saying, how like cardiopulm, it's like this whole holistic approach. But then when you go back to another class, it's like there's a disconnect, and it's taught by the same professors, but because nobody really made an effort to like see where those commonalities are. So I definitely think there's opportunity there, but I think on the ortho side, there's definitely a lot more opportunity to apply this approach. And I think it's really going to shape practice going forward, especially given how much it's like being popularized as well, and how much we're seeing how it affects like the language we use. It affects the expectations we set with athletes and patients if we take this approach. And it's going to really address some of the discrepancies we see in practice. And it's helped me better like deal with some of those discrepancies kind of going out to clinic. And just the better I understand it, the better I'm able to navigate those conversations. And hopefully some of the, the other students here are able to pick that up too, and kind of see that like having this framework at least helped me better understand how I can apply some of the things I was learning, or just because like ultimately if I relied on my ability to work with an individual and help better understand them, the better I'm going to be able to use that information I'm learning in school. So that's why neuro is very interesting, but also I think ortho there's definitely a lot of opportunity to apply those neuro concepts or principles.
Going off that, I think we maybe talked about this on the phone, but with neuro populations, a lot of time, like maybe they're in pain, but like it's all relative, and like they want to get back to walking or using their hand. Whereas orthopedics, it's like a lot of times it's not put in perspective compared to some of the more like intense populations, like a spinal cord injury or TBI. So I think you're also dealing with people who are like more willing to focus on the task than orthopedics, where a lot of times like they care about like just getting rid of pain. So I think that also changes like your view as a clinician of like, oh yeah, we can fully focus on like getting them to reach and pick something up versus like, let's work on their shoulder pain or something like that. You're muted.
Oh, sorry. And it helps better understand too where along the spectrum of recovery that they're in. And the better you understand that, the better you're going to be able to like, know whether or not you can be a little bit more focused and specific, or whether or not you're going to lean more towards like doing the thing that they need to do. And it goes back to kind of what we were saying earlier in this conversation, like do you actually need to address individual constraints at the moment, or do you actually need to address the actual performance of the thing that they want to get better at? And just this framework, and it goes back to also like constraints-led approach, understanding like the task, environmental, individual constraints, how they interact, keeping that in mind. You might be in an ortho setting and you are very good at assessing rate limiters to performance from an individual perspective, range of motion, strength, power, yada, yada, yada. But then if that's all you don't understand the task constraints, like how is the task itself influencing what movement is emerging? You don't understand the environment that they're doing it in, how that influences. But just understanding that framework, which is what they're pushing for here, it completely changes what you're looking for in especially it helps you. It's interesting. It allows you to see the affordances, the opportunities for action on your end, based on the information they're providing you. So if you better understand this framework, I think the same the same presentation that they're giving you in terms of like what they're dealing with and whatnot, you're going to be able to see things differently. I think I've definitely experienced that myself too, where I'm like taking it from this perspective, like, oh, that's useful information regarding how they're performing the task. That's useful information regarding how the environment's influencing. Whereas before, if you're just focused on like the injury, it's like you're only looking for information about like red flags, or like obviously that's important, but like the injury itself, and you're too focused. So this holistic approach is definitely, I feel, a little bit more manageable in terms of dealing with like the complexity of things. It just helps you, like I said, take the weight off your shoulder. It's been super beneficial for me as a student. So that's why I thought this was a super useful article to touch on. I actually think Quinn talked about this too in Clinical Athlete. I don't know if everybody here is involved with Clinical Athlete, but this was actually one of the articles, I think, in one of the Journal Club episodes. So I actually got to go revisit that one too.
I'll add, it's kind of anecdotal, but what you're just talking about, James, I don't know if anyone has heard of or has done like Derek Hansen's hamstring rehab. And it's so crazy because in school, like you're taught like, okay, there's an injury to the tissue. Like here are these weight room exercises we are going to do for whatever 4 to 6 weeks. And I had hamstring issues last year, and I did his protocol, and his protocol is like entirely just running mechanics drills. Bled into running mechanics, which is just super specific to the context of running. And it kind of changed the framework in my mind of like, oh, wow, like I got a lot better doing, the thing that I need to do, just scaled, obviously, than what school has taught me, which is like to break it into parts and look at my range of motion, look at eccentric strength, look at concentric strength, whatever. And so kind of just an anecdotal adage, like that's where this paper resonated with me. It was like that program was inclusive of the entire context of, like including environment, organism versus just trying to break it down. And I definitely felt like there was efficacy to it.
That's awesome. Yeah, it kind of ties into with, and my second, by the way, also my movement science class is probably one of my most favorite classes because it touched on these topics, but my second was biomechanics. And the reason why is because like, once I started to actually learn and understand biomechanics, then when I looked at movement, I better understood, I could like visualize forces. So I don't know if anybody else has experienced that from like taking, like after finally being able to understand like how load is influenced in terms of direction and how position can dictate like moment arm, lever arm, yada, 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 right? When you better understand that, then I think it goes back to like, for example, the running mechanics, like you understand positions, task demands, like what is the thing you're trying to do and what it is asking your body to do. And then if you are better able to familiarize yourself and understand and see the forces being imposed, then you can create like something very specific. It might not exist already, but like you can make like if you understand load and force, you can better understand like the demands of the thing you're trying to do. So you can create an intervention around the thing you're trying to do, right? And that's where collaboration comes in, where you can actually speak to coaches on that end. Like, hey, can you better teach me what's required of your sport or the thing that this particular person is trying to get better at so I can better understand. And I think it goes back to the example, I think, of tennis too. You know what I mean? Like if you understand the direction, the load, the position, you're going to be able to create an intervention that like is based off these biomechanical load principles, but then also tie in. I think that's where the art of coaching comes in too. This is where the art of like blending all these things seamlessly and creating this experience of like making it meaningful to the individual. And I think you're going to be better able to do that if you take this approach where it provides this framework for the things you need to look at. And that involves individual, but it also involves the thing they want to do and the environment that they're doing it in. And the better you're able to understand that, the better you're going to be flexible in creating something that's specific to that person at that point in time. Because you have to be dynamic too, right? Because what if like your condition changes like that, right? All of a sudden, and this goes back to other concepts in motor learning too. One in particular, like it's called perceptual motor calibration. Complex term for you have to constantly calibrate to what you're currently capable of doing so that you can coordinate your movement better. And so the idea is when you are injured, you have to calibrate to your new action capabilities. You can't do the stuff you used to be able to do. So if you're injured and you try to do something that you thought you originally could do but can't do anymore, you're more likely to get injured. Or like you know, and so the idea is like rehab in a way is helping you recalibrate to your current capacities and helping you better able to perceive those changes in action capabilities as you get better. And if we go back to the concept of affordances, the better you're able to perceive what you can and can't do, the better you're going to be able to perceive opportunities for action in your environment and for movement. And so understanding that and keeping that in the back of your head as you're creating a treatment or helping somebody get better, you're going to be able to make it more relevant to them, because then they're going to be able to learn the language of how they can communicate what they're feeling based off what you're doing. I think that's interesting you bring up like that, right? That program, like you're working with the hamstrings, but specific to that running, because he probably understood running very well to make it specific to loading those tissues. And I think that's pretty cool, where it kind of blends in your understanding of mechanics, load, force, the individual, the task, the environment you do. I don't know. It's just like, that's where the art comes in of like just making it something that you're not really seeing those distinct parts, but it's just kind of like this beautiful package of like, and that's something I want to work towards, get better at. And I think as students, I'm sure it would be very helpful once we start definitely working with people, making it more meaningful for them. And it's helped me. I just think it's definitely something that could definitely be emphasized more in school for sure.
For sure. That was beautiful. Do you all have any final points or talking or questions before we wrap it up? Yeah, Derek, exactly. James crushed it.
Oh, stop. I did want to point one thing out, people to check out if you want to learn more about this stuff. I mean, some of you already said that they know Rob Gray from Perception Action podcast, Talent Equation. They're based out of Australia, if I'm not mistaken, and Emergence. I'll send some info over to Chris and he can send it out. But those are 3 very large contributors to knowledge within this field, and they're facilitating a lot of really good conversations with coaches too. So if you're interested in that interaction between how this theory applies to like people actually applying it within team sports, within individual, like I think they've brought on some really cool individuals to really like have that conversation. And there's not too many like resources for motor learning out there that are like, I think, useful or kind of packageable. So Chris mentioned to me that like to create another like trying to put some like resources together to share and whatnot. So I'm going to be working on that. But anyway, I appreciate everybody here. This is awesome. Hopefully it wasn't too boring, but I think this is something that's really helped me out in school, and hopefully it helps everybody else out too.
Yeah, it was great, man. Thank you so much. Next week, we're going to have Aaron Kubal, who's a DC. He's going to talk about Ehlers-Danlos syndrome, which is pretty cool. He's going to talk about patient cases and management. And then the following week will be Andy Chen, another New York guy, talking about plyometrics. And then the final week of January would be a professor out of Harvard who's going to talk about pain and suffering. So it's going to be a little dynamic month. So James, thanks for leading it off for the first week. But yeah, thank you all for joining the party. Enjoy your Saturday. I'm assuming most of you all are starting class or clinic on Monday, or you've already started. So thanks for taking the time out of your Saturday.
At the COVID break, so I have another 3 weeks off, I think.
What are you gonna do?
Take the CSCS and do a fake clinical with Zach Gabor and fill all of my time because I have no chill. That's
Sounds great. You can play pool in that little pool table you're in.
That's accurate. I have not played pool on this table.
Yeah. All right. Well, you can. All right. Ending the call. Thank you all again.